Hello, my name is Dr. Annie Lin, and this is a narrative review I co-authored with Dr. Lily Lu Nguyen on vitamin D3 dosage for symptoms associated with COVID-19. There are no conflicts to disclose. The purpose of our narrative review was to summarize the present research to date in order to identify the dosage needed for vitamin D3 supplementation in order to prevent and manage COVID-19. Our methodology included searching the PubMed database. We looked at studies that investigated a dose for vitamin D supplementation in preventing or managing COVID-19. We included the mesh terms vitamin D, supplementation, dose, and COVID-19, which yielded us with 35 results as of December 2021. Each title was reviewed, and all studies were restricted to the English language. For our inclusion criteria, the studies had to have been peer-reviewed and included vitamin D as an intervention in the form of vitamin D3. Vitamin D3 had to have been specifically implicated for COVID-19 management, and that could have been at any stage, whether it was prevention, treatment, or management. Also, studies were included if it was a primary research paper only. For our exclusion criteria, if D3 was not studied, or other supplement forms of vitamin D were used, such as calcifidiol, calcitriol, or vitamin D2, then they were also excluded. If the study did not clearly report the form of vitamin D that was being used, it was not included, or if non-dietary sources of vitamin D were used as a main intervention, such as sunlight exposure. If the supplementation dose was not mentioned, we also excluded it. And if the studies related to a population outside the scope of this review, for instance, if the population had nothing to do with COVID-19 symptoms, we did not include it. And lastly, the study was excluded if it was a review, and that was to avoid duplication of results. We did follow the PRISMA guidelines, and here's a copy of our flow diagram. After we yielded the 35 results and we filtered the ones that met the inclusion criteria, we were left with 3 studies. And then we picked up an additional 3 studies from the references of the original 3 studies, leaving us with a total of 6. After all the inclusion and exclusion criteria were met, we included a total of 6 eligible studies in 5 countries: France, India, UK, Mexico, and Brazil, with a total of 1,451 participants in both genders, male and female, from ages 20 to 88 years. Baseline serum vitamin D levels were determined in 4 trials. There were 3 randomized control trials, 2 quasi-experimental, and 1 cross-sectional. Mortality was the most commonly reported clinical outcome, along with secondary outcomes such as inflammatory biomarkers, and there were no adverse events associated with the administration of any of the studies. The first study was a group out of France. They wanted to test whether or not bolus vitamin D3 supplementation taken during or just before COVID-19 diagnosis was effective in improving survival rates among frail elderly residents in a nursing home. It was interesting because every 2 to 3 months they would give 80,000 IUs to these nursing home patients. And when these nursing home patients were admitted to the hospital with COVID-19, they asked the question, did this patient get this 80,000 IUs within the last month, or has it been longer than a month since they got it? There were a total of 66 in the cohort, and for the patients that had gotten it within the last month, they had a much better survival than those who had gotten it further than a month out. Now, the same group out of France conducted another study. This time they looked at 77 patients. Again, they were elderly. They were in a geriatric acute care unit dedicated to COVID-19 patients, and they broke them up into 3 groups. And they basically had 2 intervention groups. The first group was regularly supplementing with vitamin D over the previous year either with 50,000, 80,000, or 100,000 IUs every 2 to 3 months. And the second group did not usually supplement, but they did receive an oral supplementation of 80,000 IUs within a few hours of being diagnosed with COVID-19. And the control group was the group who did not receive any supplementation at all. And what they did find was that the group who had been regularly supplementing over the past year had a higher survival rate on day 14 compared to the second and the third group. Out of India came the SHADE study. This was a randomized controlled trial. They looked at 40 COVID-19 positive patients who were mildly symptomatic or asymptomatic in a tertiary care hospital. They were all vitamin D deficient, as you can see here. Their levels at baseline were all under 13 nanograms per milliliter. So what they did was they gave 60,000 IUs daily in an oral solution to the intervention group for 7 days. If their levels reached more than 50 nanograms per milliliter, then they continued with the 60,000 IUs every week. If their levels had not reached the 50 nanogram per milliliter, then they continued giving it to them daily. And the 24 patients got a placebo. In terms of outcomes, they were looking at how many of them would be SARS-CoV-2 negative by day 21, and if there were any reduction in biomarkers. The results showed that 62.5% versus 20.8% were SARS-CoV-2 negative by day 21 in the intervention group. And fibrinogen, which is an inflammatory marker, was significantly decreased in the intervention group as well. The fourth study was a cross-sectional, multi-center observational study out of the UK. And what they did was they looked at 986 patients in 3 centers who received a variety of different dosages over the course of 7 weeks. They had a primary cohort and then a validation cohort, and they had a different range of dosages of vitamin D supplementation that they received. And what they found from their cross-sectional study was that high dose booster therapy, regardless of whatever their baseline serum levels were, it was associated with a reduced risk of mortality in acute patients admitted with COVID-19. This was a study out of Mexico, and it was a randomized control trial. This one looked at 42 outpatient participants who were COVID-19 positive, but with very mild symptoms, and they were not taking any vitamin D supplementation at the time. And what they did was they gave 10,000 IUs daily for 14 days in a soft capsule form, and they found that on day 7 and day 14 of the follow-up, the supplemented group actually presented with fewer symptoms than the control group, who had more than 3 symptoms, who had not received any kind of supplementation at all. Now, the previous studies have been pretty consistent with the results so far, with their associations, and this last study out of Brazil was a multi-center, double-blinded, randomized control trial, and they looked at 240 hospitalized patients with moderate to severe COVID-19 symptoms, and on admission, they gave patients a single high dose of 200,000 IU vitamin D3 or placebo, and they wanted to see if there was any difference in clinical outcomes. So here on the right, you'll see that the blue groups were the intervention groups that received vitamin D, and there was a significant increase in their circulating 25-hydroxy vitamin D levels. In a placebo group, there was no difference. Despite the fact that the intervention group had vitamin D levels that went up, they did not find any clinical outcome differences, including length of stay, mortality, or the need for mechanical ventilation between both groups. Our studies in this narrative review looked at patients that were COVID-19 susceptible or positive and looking at various outcome measures. Now, evidence over the past year suggests that 40 to 60 nanograms per milliliter is a relatively optimal range for prevention. And so in order to achieve this, the doses in our studies range from 400 to 200,000 IUs a day, and it was given either as a single dose or over a period of 3 days and up to 4 months. Based on this, it's found from our review that vitamin D3 supplementation is associated with improved clinical outcomes in patients with COVID-19, and vitamin D3 can be a potential therapeutic option. It's very attractive due to its wide availability, its low cost, particularly in developing nations, and it has a relatively safe side effect profile. As long as the patient is getting regular monitoring of their calcium and serum levels. However, our results should be interpreted with caution while analyzing this data. In conclusion, this preliminary research suggests that even though 40 to 60 nanograms per milliliter is somewhat of an optimal range for us to be in with our vitamin D levels, from a functional nutrition perspective, the actual dosing is going to really depend on the individual's unique clinical presentation. We need to make sure that there is optimal bioavailability in each individual in order to bring their serum levels up to the preferred baseline in both healthy and at-risk populations. In other words, their personalized risk factors have to be accounted for. What this essentially means is that for each and every patient and client that we have, a comprehensive dietary assessment should be made in order to assess micronutrient and vitamin deficiencies that can decrease the absorption of vitamin D. Are they consuming enough synergistic nutrients in their eating patterns, such as essential fats for absorption, vitamin K, phosphorus, magnesium that activates vitamin D? Vitamin D status is also influenced by genetic determinants. Are there genetic SNPs in the vitamin D receptor gene? And what about their production of melanin and their skin color? Are there non-modifiable risk factors such as the latitude, the area of their skin being covered, the season, the hours that they work? Do they have any contraindications based on the medications that they're on? And what about their comorbidities that have an influence on vitamin D metabolism? So in order to take a functional nutrition approach along with vitamin D3 supplementation, we have to consider the dietary patterns, the genetic factors, the non-modifiable risk factors, contraindications, and comorbidities in order for us to help our patients and clients reach that optimal level. We need to take all these things in consideration. It's not just about the dosing. Here are some of the comorbidities associated with vitamin D status and metabolism, as well as poor COVID-19 prognosis. This will be a good takeaway for clinical practice if your client comes in with a heart condition or diabetes or organ transplantation, cancer, obesity, or old age. We need to be thinking about that when we are dosing for vitamin D. To summarize everything from our narrative review, what we found was that the prevention dose was safely given from 400 IUs to 10,000 IUs a day, and the therapeutic dose was safely given from 60,000 IUs to 200,000 IUs a day. But what we should be thinking is how to optimize the bioavailability of vitamin D3 supplementation in COVID-19 patients. Now, the smaller doses, the prevention doses, are given more regularly and they can be taken daily, while the higher therapeutic doses can be given as a bolus dose or for shorter periods of time. But what we should be including is the personalized risk factors that can affect the metabolism and the absorption of vitamin D. So it's not so much the amount of the dosage per se, but it's how can we optimize the bioavailability of that vitamin D to reach that baseline level that we are looking for. Here is a copy of our poster, and I am free to take questions. Thank you very much.